the challenges in transitioning from essentially a centralized healthcare system to a fully devolved one, the challenges are going to vary across the different building blocks. I'll give you examples, specific examples. If you look at service delivery, I think under the centralized arrangement, it was very, very difficult to get that working. And simply because the accountability pathway or the accountability mechanisms holding that healthcare worker at a facility to account was a lot harder when the direct accounting officer, for lack of a better word, was actually at the national level. So I think there are lots of benefits for service delivery because suddenly the full account is there at the county, and for example, using a negative example, any complaints are likely to be addressed very effectively because the mechanisms are in place. And I also think if we get it right, the health management information systems would also work a bit better because remember, these are some of the national government had a lot of challenges getting information from the counties. But if there's a unit at the county that has a strong incentive to get the information for its own planning purposes, and you can standardize this across the 47 counties, then it should be a lot easier for the national level to tap in and have data, big data there that is fairly accurate because it's come from the administrative units in each of the counties. I think top on the list is health products and technologies. One of the major challenges that we've had as a country was trying to get KEMSA, that is the Kenya Medical Supply Agency, to be able to deliver those products to the end users, what we call the last mile supply. Yeah, it's always been a challenge because the logistics planning, quantifying what the needs for the different facilities and areas are, getting the distribution mechanism working in an efficient way and getting the product there at the right time, in the right state is a challenge. KEMSA has put a lot of effort getting this in place. But now suddenly procurement and supply management has been devolved to the counties. Now, your guess is as good as mine. In theory, that basically means counties actually have a lot of power to decide how they are doing procurement and supply management themselves without KEMSA. The good thing is policy has tried to put mitigating measures in place to ensure that KEMSA remains the port of call. But the challenge still remains. If each county is supposed to do its own procurement, then you have what we call fragmented procurement, which pushes the costs up. Because the world is moving towards what we call pooled procurement, which actually helps lower the costs. So obviously there's going to be quite a bit of, there's some teething problems around procurement and supply management of commodities, but also healthcare financing. We are trying very hard as a country to have universal healthcare coverage. And healthcare financing is a major component of universal healthcare coverage. In fact, it's almost 50%. Because when you're talking about universal health coverage, you're talking about financing and providing the services. Now, how do we finance these services in a way that actually works for the population? You actually need to make sure that when Tracy falls sick, she doesn't actually have to pay before she sees a doctor or she sees a nurse, whoever is going to give her care. And the way we do this is by creating what are called prepayment mechanisms. So a prepayment mechanism basically means you pay into an insurance, the money is pooled in one central pot, and then whoever falls sick is actually taken care of based on that pool. So that pot actually helps subsidize, cross-subsidize, for lack of a better word, the ones who are sick with the ones who are well. And then, of course, the ones who are older, who are likely to fall sick, are protected by the ones who are younger, because you all share one central pool. So that works very well at a national level. Now, what happens when each county decides it's going to try its own health financing mechanism or prepayment mechanisms? There's a real risk of having 47 small pools. And the thing about insurance, it only works well if the pool is big enough, is big enough. Because then you can actually cover a broader range of diseases and you'll actually have what we call more depth. I think devolution is going to have to come with different challenges across different areas. I think on the balance of everything, it's actually a good thing, and especially since accountability and service delivery have always been a major problem. But I think counties need to recognize that there are certain functions that it's not in their interest to take on themselves, but rather they work better when they're doing this as a national government. And this doesn't just apply to devolution and counties. We've heard about insurance for teachers, and the Teacher Service Commission signing a deal with perhaps a private health insurance firm, which I can't talk about. That actually fragments the pool. So you actually end up with a situation where teachers are looking for their own, doctors are looking at their own. That is not a very smart thing to do if you actually want to have universal health coverage. You need that pool that balances the risk properly.